our laws as it pertains to substances are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous.
I'm a doctor, for sake. Where the hell do you think I learned that?
I'm just saying, you go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real.
We used to get these calls on Loveline all the time.
Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want help stop it, I can help. I got a lot to say. I got a lot more to say.
We're going to get right into this and your calls as well at 984-237-3739. People are already piling into Dr. Bruce Patterson. Let me give you his particulars. You've known him before on this show, and of course, Dr. Yo and I have been talking about him for quite some time. Associate Professor of Pathology and Infectious Diseases, as well as Director of Virology at Stanford. As undergraduate in molecular biology from University of Michigan, and the medical degree from Northwestern. Dr. Patterson, welcome back to the program.
Thank you, Dr. Drew. It's a pleasure to be back.
So a lot has changed in the 3 or 4 months since we were last with you. And, of course, we've been chatting with Dr. Yo and keeping up with him, who's also, by the way, lurking, watching us, or should I say stalking us on the chat, the restream. Usually, by the way, Dr. Patterson, he stalks us while he's doing anesthesia, which is not exactly reassuring, but okay. If he can do it, if he can pull it off.
He's amazing. He's a multitasker.
And it's funny, as I was thinking about going live here, I thought what strange bedfellows from all the disciplines of medicine this whole COVID thing has brought together, right? Your pathology, virology, I'm medicine, addiction, medical, addiction stuff, Yo, anesthesia, and yet we all are interested in solving these problems and thinking about them. And I've never thought so much about the cytokine system and particular, cellular immunity functions as I have in the last 6 months. So you were one of the first to alert us about the Rantes, or sort of at least adjusting the Rantes system. Where are we now since we last talked to you in terms of the cytokine activation system and some of the research and therapeutics there?
Well, again, I think the theme has been how can we curb this overzealous immune response, and I would say chaotic immune response that we see during COVID, with the fact that there's still a virus replicating. And so you have to balance your ability to stop viral replication and what that entails, while also curbing and quieting down the immune system that's trying to get rid of the virus.
Right.
So it's a very fine balancing act. And you're seeing that in terms of some of the therapeutics that are coming out, where you are seeing a combination of, for instance, Regeneron's, antiviral neutralizing antibodies with, a immunosuppressive like a Decadron or some of the other immunosuppressives. I think early on, we really felt, and from my experience in virology, if you weren't going to treat with a good antiviral, I think it's, for me at least, it's a little dangerous to be giving steroids, and maybe dangerous is a difficult word, but you're competing against two different outcomes, and that's why we really felt early on that an immune modulator, like one of the drugs that targets CCR5, which is a receptor that controls the movement of immune cells to the appropriate places, might be a better bet than a immunosuppressive, which really shuts down the function of the immune cells that are trying to control the virus.
And yet steroids have shown some clinical utility, right? I mean, they're just clinically, the data is there to support using it. It's just a question of when and how much, right?
Exactly. And again, they have formed, the function that they're intended to, and that is to quiet the immune system by suppressing it. And, I think we haven't seen, luckily, or maybe we've seen in to some small extent, other opportunistic infections because of the steroids, or, we're not measuring viral load enough in the lungs or in plasma as we did to show that giving steroids is causing an increase in COVID replication. So, they're doing what they're supposed to be doing, and at the end of the day, in very severe cases, I think there's some benefit to that because you start to think less about viral replication when patients are really in a very sick state. Yeah.
So I want to make sure I heard you correctly. So you did do a study where you looked at viral shedding during Decadron therapeutics?
No, we looked at it with leronlimab way back in February and March, where we were able to show that by blocking this CCR5 receptor, we were able to increase the CD8 cells. And now the CD8 T cells, like CD4 T cells in HIV and AIDS, were significantly suppressed in these critical patients. And that was causing an immunosuppression in and of itself. And we found that CCR5 blockade could bring back the CD8 counts, keep them from being sequestered solely in the lungs, and also brought back T cell function. And oh, by the way, at the same time, it lowered viral load in the plasma. And that's something that, other even antivirals haven't been able to show a distinct pattern of decrease in plasma viral load or viral load from other sources such as the nose and the lung, which are more difficult samples to come by.
And was that leronlimab? Is that the CCR5 inhibitor?
Yeah, that was from the early leronlimab studies that that we performed. And again, I think we saw great results in the so-called EIND patients where they were emergency use authorization. And I think we're still in obviously clinical trials with leronlimab, and we're seeing in a trial I'm collaborating with on Maraviroc, which is Pfizer's version of a CCR5 inhibitor. We're seeing the same types of response. Interleukin-6 going down, which is a hallmark of the cytokine storm. CD8 counts going back up. Viral loads going down. Receptor occupancy by the drug. So we're seeing very similar patterns, with the class of drugs that blocks CCR5 across the board.
And Maraviroc is in use for HIV. Is that correct?
That's correct. It was actually the first drug CCR5 inhibitor approved for blocking the receptor that HIV uses to get into a cell. Now, back in the day when I first started looking at CCR5 in the mid-90s, all we thought about was CCR5 as a co-receptor for HIV entry, when in fact it has a very elegant, I've called it the quarterback of the immune system, because it's really responsible for getting the necessary immune cells where they need to be. And they're expressed on a wide range of immune cells. What's interesting is they're expressed on cells that have antagonistic functions. So CCR5 is expressed on effector T cells, which are the ones that fight off virally infected cells or cancer.
Like the so-called killer T cells?
Killer T cells. And then they're also expressed on a cell called a T regulatory cell, which shuts off the immune system so that you don't go on to have an autoimmune response. So, it's a fine balance with CCR5 between its good effects and potentially bad effects. But I think that really comes down to the density of CCR5 on these particular cells. And by knowing that, we're able to manipulate the immune system to be more favorable by inhibiting the bad cell and allowing the good cells to still function. And I think that's also part of the strategy for cancer.
Do you have a theory why the CD8s come up when you block CCR5?
I truly believe it's basically redistribution. I mean, obviously it's not stimulating the production of more CD8s, but I think what we're doing is we're inhibiting to some extent the sequestration of all the CD8s in the heavily inflamed lungs, and we're allowing the CD8s to increase in the peripheral blood and perform normal functions elsewhere.
I also was thinking, in terms of you were talking about both the inhibitory and the directive function of CCR5. I mean, it's just the way our body works is feedback loops. I mean, that's whether it's the endocrine system or the immune system or the neurological. So there's just all these always feedback loops, and that's how it regulates.
Absolutely, it's very elegant, and I think the PD-L1 pathway and the PD-L1 in cancer, which obviously several individuals shared Nobel Prizes for immuno-oncology this year, really taught us how we can manipulate our most powerful weapon, and that is the human immune system, and we can manipulate it to do what we need it to do. And I think that's why it came out early February or March and said we need to stockpile drugs that allow us to manipulate the immune system in a way that can target emerging pathogens that our body has never seen before, nor do we have drugs on the shelf to treat them, because we need like a broad spectrum weapon against the anything and everything that may come along in the future, whatever that may be. Obviously, I have some of our own thoughts, but I think it's paramount to developing a emerging infection strategy as a nation and as a world to combat whatever may come our way.
It's interesting to me that the last time, where's my feedback? Sorry about that, everybody. But the last time I saw this kind of leap forward in understanding the immune system was during the HIV epidemic. And now I feel like this is similarly preoccupying us in such a way that very different sort of aspects of the immune system we're worrying about. But once again, because we're worrying about it, we're learning about it, and we're creating therapeutics targeting it. And I keep thinking that what's going to really be changed as we come out of this is how we treat sepsis, or how we think of it at least, and probably how we treat it.
Yeah. Well, I think you're absolutely right, and I think that's why you're seeing a lot of us who cut our teeth on HIV and began our research careers in HIV, because like I've said in various articles, it's not my first pandemic, and I think there's a lot of lessons that we learned back then, good and bad. I mean, we went through developing a vaccine for HIV, and it ultimately wasn't successful. And so, we saw the data coming out. We saw a lot of the hype, and there never was a vaccine. There's never been a vaccine for hepatitis C. I'm cautiously optimistic about the COVID vaccines, but we know from these prior pandemics and in treating HIV and hepatitis C that therapeutics are very, very powerful. And we're going to need anything and everything. We're going to need the vaccines. We're going to need therapeutics because nothing's 100%. And then I know we'll get into it a little bit later, but then we have the long haulers that have a post-viral condition that is possibly affecting 10 to 30% of people who have COVID. And it's devastating. And the stories I've heard from hundreds of people talking to us in the trials that we're doing has been just heart-wrenching. So there's all the elements of a severe pandemic here, including the after effects of infection once you've recovered. So
right. So let's get into that, which is I know something Yo has talked to us a lot about, and you've been very involved with. If you want to hear more or get involved with this study, you can find out more at info@incelldx.com. So it's info@incell, just like in the lower right-hand corner there, incelldx.com. And let's talk about the long haulers. What are you learning? What's in the study? Let's get into the weeds a bit.
Yeah, and it's fascinating, and we're just finishing up a paper where we did extensive machine learning, bioinformatics, and AI to really look at the immunology of long haulers relative to active COVID, and it's a completely different immune environment than in active COVID. We've developed an algorithm. We've developed what's called a long hauler index, where we have found a commonality in a very heterogeneous clinical presentation that defines long haulers, in addition to other immunologic abnormalities that we are starting to figure out are associated with symptoms. And I think we talked a little bit about this on your last show.
And what is in that those criteria?
Yeah, so we looked at we did high parameter analysis of all the different immune cells and immune cell subsets to try and look for abnormalities there. We looked at the inflammatory profiles, cytokines, chemokines, et cetera. And, when I talked about long haulers 3 or 4 months ago, I said, wow, they're very heterogeneous. And indeed they are. If you look at the symptoms of these individuals, every story is different. And that's why it's going to be very difficult to conduct trials based on symptoms because, everybody's different. But amongst the weeds, so to speak, and amongst the numerous different immunologic abnormalities, we found a pattern. And that pattern is indicative of a very appropriate immune response, one that looks like an antiviral immune response. And it looks like an immune response based on some sort of persistent antigen exposure, persistent even viral exposure, which we're actively looking for right now. But two things were very curious to us. Number one, two abnormalities in the immune cell subsets. One was the B cells in long haulers are twice normal. Now, B cells are a type of immune cell that is commonly infected by Epstein-Barr. Epstein-Barr, of course, causes chronic fatigue and other clinical diseases, but chronic fatigue and fatigue is a common symptom of long haulers. Cytomegalovirus, or CMV, which is common in transplant recipients, is another virus that's been associated with chronic fatigue, which we're looking for. In addition, there was another subpopulation of a cell type called monocytes that was elevated that we had previously published not only got infected by HIV, but also was infected by hepatitis C. So it seems to be this long-lived reservoir for viruses that somehow escape drugs sometimes and tend to hang around for a long time and continuously present antigens to the immune system, which causes this hyperimmune activation that we're seeing in haulers.
Did you always have the assumption that there was a persistent antigenemia or antigen exposure, or did you ever have a theory that it was just some sort of uncontrolled cytokine activation?
You're exactly right. I think it was the latter. I wasn't looking for persistence necessarily until I started seeing two of my favorite cells from a virology standpoint remain elevated in long haulers 8 months after they had COVID. And like I said, that on top of the fact that the COVID immune profile is completely different than mild to moderate COVID, severe COVID, normals, et cetera. And like I said, is indicative of a persistent antigen exposure. And that's really what led us to start to think about what can be causing this persistent antigen exposure. And, the most likely cause obviously is some hidden reservoirs of virus. And it may not be COVID. And it could, like I said, it could be EBV, it could be CMV or the other viruses. And again, that's a lesson learned from HIV, where there's latently infected HIV cells. I mean, COVID doesn't have a latent phase like the herpes virus family, or like HIV, but nevertheless, we know that HIV also infects these macrophages that are long-lived and may not respond to the same drugs that attack the virus in T cells. So again, we're pulling in all of our weapons from the HIV front in terms of how to look at COVID.
But when you describe how COVID affects the immune systems differently, it makes me think that the host that the virus is taking advantage of different host genetic mechanisms, because these are so very different the way you describe it, right? Whether it's hiding in a monocyte or whether it's overwhelming some other part of the system. It all sounds like each is a genetic variant almost in the host.
Well, again, I think that's a great theory, and listen, we haven't ruled anything out at this point. I mean, I think we finally got our arms around the what is it when we're talking about long haulers in terms of the immune system. And again, we did the bioinformatics. We know what that looks like, and we know it's very different from severe and mild to moderates. But we haven't answered the question why yet. And I think, until we do, I think we're left with sort of a menu of different treatment options that may work, may not work, may work for a period of time, but not work long term. And we're developing a matrix and a database based on patients that we have treated, based on the information that we gleaned from our bioinformatics, and we'll keep a list of those. But I mean, clearly there isn't a magic bullet right now that treats everybody and relieves their symptoms and to the point where they're back to normal. But the bottom line is we have a metric that is non-subjective that we can use to monitor improvement. And sometimes that's the name of the game, when you can say, well, you hear from the patients they're improving, and then you can associate that with changes in their immune system that are approaching normal or getting back to where they were. So I think that's been really gratifying over the last month in putting that puzzle together and those pieces of the puzzle together.
I guess not everyone knows what a long hauler is. It's people that have persistent symptoms after the acute illness is over with COVID, essentially. And Dr. Yo, tell me, I guess Dr. Yo is talking about some test kits that are coming out. Is that correct?
Well, IncellDX has developed some tests and some reagents that we're partnering with various laboratories around the United States and around the world to offer these tests widespread, and then also take the appropriate measures to test and seek approval for, the index that the bioinformatics and the index that we've been using to say, is somebody getting better or not. And, that's what we've been doing for the last 4 months at IncellDX. And, our crack team has been working 7 days a week, long hours all day long, trying to put these pieces in place so that we can implement a chronic COVID kind of treatment initiative in the U.S. and hopefully throughout the world, so that as we're gaining more knowledge about the immunology and what therapies may or may not be working and then for how long, and creating that database, I think we're getting close to being able to put the puzzle pieces together until we find what the underlying cause is.
Dr. Yo and I have some enthusiasm for ivermectin, both in early treatment of COVID, and I'm hearing for some of the long haulers as well. Do you share that? Do you have concerns about that? And do you think the mechanism fits what you think is going on physiologically?
Again, Dr. Yo has used ivermectin on some of the patients that are in our studies, and for the most part, we've had some good success with it. As we've had good success with steroids in some individuals, we've had good success with Maraviroc in some individuals because they continue to have high rantes as long haulers, which is incredible because that was something we figured out about COVID way back in February. And not only did they have it during active COVID, they had it in long haulers. Conversely, rantes and rantes is not a good marker for distinguishing between long haulers, active COVID, severe COVID, mild to moderate. So it didn't go into our algorithm for long haulers because we had to look for biomarkers that were different amongst long haulers, severe COVID patients, mild to moderate patients, and normal patients. So, clearly, rantes and CCR5 are still involved in long haulers, as we see that elevated in a number of them.
Do you have any opinion? It just happened that a friend of mine was treated, or a friend of a friend was treated with vasoactive intestinal peptide. Do you have any feelings about that therapeutic?
Yeah, again, I've also seen some data on VIP, and I think it's impressive. It's an inhalation drug, which I think has some significant benefits as opposed to IVs, especially for mild to moderate patients who may or may not be hospitalized. And I think its mechanism, which in relieving the inflammation, it actually lowers rantes. So yeah, I do have some. I have a good feeling about VIP.
Nice. Let me take some calls here for you. This is Joe. Go ahead there, Joe.
Good evening, Dr. Drew. First, I want to thank Dr. Patterson and Dr. Yogendra for, just helping out these long hauler patients that have been, suffering for so long, for months, dealing with long hauler COVID. My question, Dr. Drew, you actually just answered, you had just asked my question about the different treatments, but I want to ask, Dr. Patterson, have you also used supplements like vitamin C and vitamin D to add on to the ivermectin and steroids?
Good question. Or have we seen anything with supplements? Yeah.
I haven't seen any data. By data, I mean before, after treatment. A lot of the things that we've tried with long haulers, we have before and after immune profiles. So we can say exactly what's working, what's not working, and if it is working, why is it working? We don't have that data individually for supplements, but my position on supplements is do no harm. Certainly vitamin C, vitamin D, a lot of zinc. There's no reason not to include them. So why not? It still remains to be seen and independently whether or not they they have a distinct function. But from my standpoint, why not take them? I mean, they're good. They're good supplements to take anyway.
Much like HIV, my sense is that COVID is affecting neurons. What's your sense of that? And is that part of the long hauler, and is that where maybe some of the reservoir hides out?
That's such a great question, Dr. Drew, because literally just this morning, as I was finishing one of the tables for the paper we're submitting, I saw levels of a compound called VEGF, or vascular endothelial growth factor, that were 4 times the levels of normals and mild to moderates in long haulers. So it's significantly elevated. And VEGF has been associated with peripheral neuropathy, as well as obviously blood vessel growth. And the 2 common symptoms, and again, we're kind of creating a matrix out of symptoms plus immunologic findings, but the 2 symptoms that I see most associated with VEGF are numbness and tingling, coldness in extremities.
Oh, so literally there's a correlation between this mediator or protein and symptoms.
Yeah.
Wow. That's a big deal.
This is breaking news, and it's still early, but at least from a first glance, that and this burn, we've heard several patients talk about burning sensation, especially in the jawline. And there seems to be an association with a burning sensation and VEGF, which would make sense and could be either part of the peripheral neuropathy or I doubt it's actual blood vessel growth, but it could be vasodilatation causing more or less a flushing or because of a burning sensation. But yeah, very, very interesting when you start to have a large profile with many biomarkers and start to associate the biomarkers with the symptomatology. I mean, obviously with IL-6 and IL-8, we know muscle pain, joint pain. I mean, those are common arthritis cytokines that are elevated. TNF-alpha, again, with depression, which I think I mentioned previously. But this association with VEGF was something that we just looked at this morning.
And is VEGF a sign of myelin injury or demyelination?
No, it's not. It's just an inflammation that seems to affect the peripheral nerves, causing a peripheral neuropathy. We don't know, what the mechanism of that is yet, since we barely looked at it this morning.
I'll tell you what's interesting to me. I got to tell you, just glancing at the literature, NAD comes in right away as a NAD NADH metabolism comes in right away. Be interesting to see if these people responded to NAD infusions.
Yeah, absolutely. And again, we're right at that stage where we're starting to get our arms wrapped around it. And like you just said, I think coming up with rational approaches to some of the data that we have in hand is what we're all about right now.
Early on, and I'm sort of involved with the nicotinamide riboside people. I'm just fascinated by that's the true Niagen people. And they're not talking about it because it's not at that stage yet, but they have some observations early that system is affected by this virus. So that's all kind of caught my attention. That's very interesting. This is another interesting thing I was wondering about. You may or may not have an opinion about this, but Nathan has a question.
Yes, Dr. Drew. I was just calling in to ask, I've been listening to this conversation. It's actually a really interesting one, but I was calling in to ask why they weren't talking about nasal sprays, first of all. And there was a bunch of other questions I had for Bruce or Dr. Peterson after that.
Well, let me frame the nasal spray. Several different nasal sprays have been associated with clearing virus and maybe preventing cellular entry. And I looked at some of that data because people have brought it up to me, and it was impressive. And I wondered why it wasn't something more in the public lexicon. Do you have any idea about that?
Again, it's trying to sort through these observations in these small studies where they first, talk about different approaches, and certainly something, like a VIP, which increases the surfactant and presumably blocks viral entry as well. I mean, these are all very exciting that are still, in their infancy and need to be investigated in clinical trials. And again, I think the list of potential therapeutics is well over 150 now since the last time, I looked at it. And so, and the thing with the pandemic, just like we did with HIV, we didn't rule anything out. Yeah. And I think that's the appropriate perspective to take. You can't be a naysayer and say, almost like a reflex, that's not going to work, because I think we've been surprised before, and I think we have to look at anything and everything.
Nathan, the other question?
Yeah, well, my other question was there's actually, you were talking a lot about HIV. There's actually a group out of Pitt State, I believe, that they're actually using, it was an HIV, and I can't remember the name of it. I mean, I could go look it up, but they were using an HIV drug that, you would use after unprotected sex. But it actually blocked the ability of the HIV virus to adhere to the tissue. And that same thing, that same compound, it's a seaweed extract, but that same compound they're using at Pitt State and doing research on using that in a nasal spray because they've already shown that blocks viral.
I know there are several.
SARS-CoV-2 virus.
Yeah, and I know there are several candidates out there for very targeted blockade of the ACE2 receptor. So that makes perfect sense to me. And what I like about that is that may one day be the way to prevent the common cold, because that may be what comes out of this. So this might be very important research in the long run.
Well, I think the other thing in response to Nathan is the fact is leronlimab and maraviroc are both HIV entry inhibitors. And so we are repurposing them for their role in the immune system as opposed to their role in viral entry. But what's very interesting is, when I first saw viral load go down with leronlimab and CCR5 blockade, I was curious as to whether or not there'd be a direct antiviral effect that was non-receptor mediated. And now there's a paper out, or coming out, at least it's in preprint, about maraviroc inhibiting COVID transmission, but non-receptor mediated. It inhibits the cell-cell fusion and cell-cell transmission of virus, which we see in HIV as well and other viruses, where it's the virus isn't released free and then finds a cognate receptor and then gets into a cell, but rather cells are in close proximity and by membrane effects are able to transmit to cells that are they're basically adhered to. So again, I think we're looking at all of that, and there are a lot of common themes between viruses, and I think we're exploring a lot of those as it relates to COVID.
I never thought about cell-cell transmission. I mean, we're all, we're so trained to think about humoral spread. Yeah. That's fascinating. Sure. Let's get Kim. Kim, you have a question. Thanks for holding.
Yeah, hi, I'm calling from Traverse City, Michigan. This is for Dr. Patterson. I'm way out of my element here, but my simple question is, I would love to hear your opinion about herd immunity. I know that there are people out there pushing that, and that I recently read that in Sweden it's starting to fail. And a second quick question is, I've never understood why they say if you wear a mask, it protects the other person, but it doesn't protect you. It makes no sense to me. If it can't transmit one way, why would it work the other way? So those are my two questions.
Got it.
Well, first of all, I love hearing from a homie from Traverse City, Michigan, which is near my home in Frankfurt. So I appreciate the hometown crowd weighing in. In terms of herd immunity, that was something was talked about very early, and several things have affected herd immunity. And yes, it pretty much failed in Sweden, and I think a lot of it was because they have shown that neutralizing antibody that is produced following someone getting infected by COVID lasts for about 72 days. Cellular immunity maybe lasts for a little bit longer, maybe 6 months. But, and this is the conundrum when you talk about, the vaccines, is that herd immunity, people with natural immunity against the virus, it lasts maybe 2.5 months to 6 months naturally, so that there's not enough protection, not long enough protection for a population to develop herd immunity. And yet we're now staring at vaccines which are inducing immunity, and indeed I think they are very capable at doing that. But the big question that remains, especially in my mind, is how long? And whatever immunity that is induced by the vaccines, how long is that going to last? Is it neutralizing antibodies and cell-mediated immunity? And how long can we expect those, to be out there and be protective?
I know that data is being looked at repeatedly in terms of particularly the cellular immunity. There was something that came out from La Jolla Institute. Whoop, I just erased it, I believe. Yes, I did. No, here it is. Let's see. Spike IgG stable over 6 months. Spike-specific memory B cells more abundant at 6 months than at 1 month. And CD4 and CD8 cells declining half-life of 5 months. So that's pretty good.
It's good, but when you think about how many doses and how many boosters you're going to need to get through this pandemic and the number of people, those are orders of magnitude. And again, I think if you can do widespread vaccination, and again, supply is also a big issue with vaccines, we'll see where we end up with that. But I think if we can have a program that institutes vaccines that have, some time frame of protection, and also roll in effective therapeutics, then I think we have a strategy that can, at very least reduce the death rate, because I know we can keep people from moving on to more severe disease with these combinations. So I think that's the name of the game.
And as far as the masks, I would say that the main thing we're trying to do with putting it on ourselves is to prevent droplet spread. It doesn't protect you against aerosol spread. I think that's essentially what they're talking about when they talk about it. But obviously, 2 masks is better than 1 when it comes to droplet spread, and it has some effect on aerosol depending on what kind of mask you're using. So I think that answers that. We have to wrap up.
No, we don't.
Oh, we don't now.
We're going to do the test at 4 o'clock, and everybody's going to watch, and then you're going to keep taking calls.
So excuse me, Dr. Patterson, I have to do a television show from home today because I traveled, and so they're quarantining me for a couple of days. And so they want to do a technical test in 10 minutes, but I'm confused. Why don't you do it?
Because I'm just testing. We're just going to, okay.
Do you need me to do it is the question.
No, is my mic on? There you go. Okay, so Anthony could only do 4 o'clock for your Fox 11 news hit, which is at fox.com/live.
Fox11.com.
Fox11.com/live. And so we're just setting up the Zoom, and we're going to test it really quick, and then they're going to make sure the shot's good, and then they're going to go. But
do I need to get out of this seat and get into that seat?
No, you're right there. Look, you're on the Zoom right now.
Oh, so I keep doing what I'm doing.
It looks really good, too.
Good. Right,
I have a new camera set up. I was going to try to do it with the big system, but I'm just going to use my Mac so we don't have to interrupt the show.
All right, good. Well, then we'll keep going. I have lots of calls for Dr. Patterson. It does not surprise me that we do. So, Brittany, go ahead.
Oh, hi. Can you hear me?
I do.
Oh, great. Well, my name's Brittany. I'm calling from Jackson, Wyoming. My boyfriend is a long hauler, so I have a vested interest in this. We actually sent you his blood last week to see what you can find out. So I'm just curious with the long haulers who you're seeing, what kind of improvement you're seeing them make, and are you seeing any long haulers get worse at this point?
That's a great question. No, we're not seeing long haulers getting worse, and we are seeing people getting better. There's no question about that. I think, like anything, how long they feel better, what they feel better on, all of these things are going into our database and coupling it with extensive laboratory analysis so that when we do come up with a combination or we do see something that is effective, we tend to know why it's effective. And there's nothing like that. You can't separate treatment from diagnosis and analysis, in this case, of the immune system. That's the only way you're going to know at the end of the day what worked, how long it worked, why it worked, and the correlates of reduced symptoms and whatever biomarker may be changing with therapy. And that's how we're going about it. Like I said, with the VEGF story, we've seen it go down in steroids. Obviously, the neuropathy has gotten better. I mean, peripheral neuropathy is reversible. So I think there's hope, and I think there's hope for all long haulers. I mean, I think this is new. I think we're getting to the bottom of it, and we've seen a couple of patients who have sent in their blood who have Lyme disease, long-term Lyme disease, and I think, as Dr. Drew mentioned, what we're learning through COVID, I think, is going to have really important implications in other, chronic post-infectious disease processes and cancer. And it's the exact same thing that happened with HIV. Yeah. We got into genomics, we got into sequencing of viruses and understanding relationships to severity. And I think the same thing is going to come out of this pandemic if you're an eternal optimist like I am and say, at the end of the day, we're going to learn a lot about the human body, and we're going to be better off for it.
Walter, go ahead.
Hi. Hey, big fan of Dr. Drew. Thanks for having on Dr. Patterson. Okay, so basically, I'm a long hauler myself, been following this for a while. And, it's funny because when I go on like Twitter or some places, there's some people that are, it's actually interesting because they're like Japanese too. They're going around saying, it's AIDS and all this. And it is kind of like fascinating that it took an HIV doctor to kind of like do this research. So it does kind of trigger this like doomsday fantasy to me that I would like to be more relieved about. And I'm kind of curious, like, what is the evidence that there isn't like a lot of stuff going on that we don't know about? And that, like, what is the evidence that there's not some really gnarly stuff going on, and it could be in people that aren't even showing these symptoms yet?
So let me make sure we got your question. So you're worried that the long hauler syndrome is associated with some sort of progressive problem, right, that we don't know about yet? Right.
Yeah. I'm aware it's not a retrovirus, right? But we're seeing persistent symptoms, and we don't know what the 3 years down the line consequences are. Like, people are talking about herd immunity in this. It seems a little bit like rolling the dice when you don't know. Yeah.
Well, of course, but I would say we do know. We know a ton, and you just pointed out that most people get better, not worse. It's very different than HIV and AIDS, where 100% of people had trouble.
Yeah, and I think the other thing is you see a lot of HIV investigators active in the fight against COVID, and the reason is this was HIV was a virus that intimately involved the virus and the immune system, and a profound disturbance in the immune system by HIV. And so I think, being a virologist and a pathologist, we were trained to figure out this, again, the elegance of the immune response against these viruses and how the interplay between the virology and the immunology, when you can have a situation where the immunology is very appropriate against the virus, like I bring up shingles a lot, where, we have a good antiviral against the virus that causes shingles, and we add in steroids because it's the immune response, the vigorous immune response, that causes the nerve pain. So you with viral infections, it's very hard to separate the virology from the immunology, but by no stretch of the imagination are these two viruses the same. In fact, like I said, we saw decreases in CD8s rather than CD4s in COVID, yet, those patients are somewhat immunosuppressed. So there's a lot of common themes, but I think that's why you see a lot of us from the HIV world working in COVID, because, like I said, we've been there before.
Yeah. Interesting. I'm sorry. Somebody sent me a note here about vitamin C. Did you have an opinion about how vitamin C and how it works?
Well, I mean, other than Linus Pauling winning a Nobel Prize for it, I do think it has.
Wait a minute. He won the Nobel Prize for discovering the alpha helix.
The beta-pleated sheet.
He did?
Of proteins. Yes. He was proteins. Watson and Crick were DNA.
Wait a second, because I went to high school with his grandkids. He was always pictured with an alpha helix, not a double helix, just the first alpha helix.
It was actually a folded protein.
Okay, got it.
And then obviously vitamin C. But vitamin C for a long time we know that it has some antiviral activity. So I've always been a big proponent of vitamin C. So,
gotcha. That's kind of what I thought. Leopold, have at it, Leopold.
Hey, Dr. Drew, how you doing? And it's wonderful to have Dr. Patterson on. Real interesting. I want to circle back to something you said earlier in the podcast regarding the virus kind of hanging out or hiding in neurons. And is it possible that, that brain fog that is occurring in the long haulers or even some of the mild symptoms, the folks may experience, a reoccurrence based on the virus expressing itself if there are certain environmental conditions that activate it?
So good question, Leopold. Thank you. We were sort of using the term hiding a little casually, and he's sort of calling us out on that. So go ahead. I'll have you answer. Yeah.
Yeah. I mean, I think it's a good point because these viruses, like the herpes viruses, have a latent phase where they're just there and it's hard to get rid of them. I mean, there's antivirals that you can attempt to get rid of the herpes viruses, but CMV is a chronic virus that affects transplant recipients. But when I was at Stanford, there was a big program in looking at CMV and chronic fatigue, so it's definitely associated with chronic fatigue. Epstein-Barr can live in B cells for long periods of time, so viral chronicity is not that unusual, and so that's why I'm not, number one, I think it's a good thought that viral chronicity, and it may, like I said, either COVID or others, may be at the bottom of the long hauler syndrome, and we're looking for it. But the bottom line is, some people have seen, COVID virus in the gut. We've been looking at it in these various immune populations, and they do infect. It does infect this monocyte population that's elevated in long haulers. So we're pursuing that even more. It's very sophisticated technology. If it's there, we'll find it, but it's certainly not replicating to the point where it's easy to find. And I think that's the point I'm making. And I don't know if the effects on nerves are direct viral pathogenesis or indirect through inflammation or inflammatory markers like VEGF, like I explained before.
Thomas.
Hi. Can you guys hear me?
We do.
Yeah, awesome. First of all, Doctor, thank you very much for your work. Really, this matters so much to many people. It is very inspiring not only to MDs, but also to have scientists like me that really want to do some good in the world. But I'm also a long hauler myself, and I wanted to know if any of the markers that you have found may explain the shortness of breath and that many people are experiencing. And if you could speculate a bit about if people will get better even without treatment over time, or if treatment will be a pattern. I've read that even other viruses like Ebola can leave lingering symptoms for long periods of time.
And Thomas, tell me a little bit about your shortness of breath, because you certainly are not manifesting shortness of breath when you speak.
Mm-hmm.
No, it's intermittent. And yeah, the shortness of breath is really intermittent. It just happens out of the blue.
Is it? Let me ask you this:
fine, but I don't know.
Is it? Hang on. Is it exertional? Is it in the middle of the night? Because you are speaking in long phrases without taking a breath here, so your lung function can't be that bad.
No. Okay, yeah, no. Right now, yeah, 100% no shortness of breath. The shortness of breath can happen at any time. I could be in the computer and I start feeling like I need to get more air, and I feel like really air is not going in. So it's
air hunger you get, and do you have trouble? Do you wheeze or anything?
No wheezing.
Okay, and any neurological symptoms?
No.
Okay, because that actually, Dr. Patterson, is very intriguing to me, because air hunger is not shortness of breath; it's air hunger, and that can be anything from gastroesophageal reflux to anxiety to something neurological to some airway reactivity, some asthma-like stuff. But that's not shortness of breath, which is kind of fascinating to me.
Yeah, I think you're right, Dr. Drew. I agree with you 100%. I think there's a perception of shortness of breath. I mean, if you looked at the pulse oximeter, their O2 sats would be, in the high 90s, and so they're really not short of breath, but there's a perception of a short of breath. And some of these, this inflammation in the long haulers, we know it causes tachycardia or racing of the heart. That can easily be associated with a perceived shortness of breath. So, again, the symptom profile of the collective of long haulers is extensive, and we're just now embarking on associating various symptoms with various inflammatory markers in the immune system.
Dr. Patterson, can you stay with us? I've got lots of calls for you and lots of comments on our restream. I'm going to take a little break if that's okay. You have time problems?
Yeah, absolutely.
All right, so we'll take a little break and we'll do maybe 15 or so more minutes with Dr. Patterson. We'll be right back. As we're gradually moving back to opening schools and businesses and, of course, our in-person interactions, I want to remind you, this is all time with cold and flu season getting going. Staying hydrated is key to helping your body deal with the added stress and with the upcoming flu season. My regular fans have heard me talk about a product called Hydrolite for a long time now. It's an amazing rapid rehydration drink. It's a mix that, well, we're obsessed with here. I'm excited to announce they've just released Hydrolite Plus Immunity, just in time for cold and flu season. Hydrolite Plus Immunity starts with their fast-absorbing electrolytes and adds a host of immune-boosting ingredients. Each single-serve, easy-pour drink mix contains 1,000 milligrams of vitamin C and 300 milligrams of elderberry extract, creates what is hopefully immune-boosting formula that's high in antioxidants and zinc. Combining this with Hydrolite's 7 key electrolytes, it's a fantastic way to stay proactive and properly hydrated. Hydrolite Plus Immunity comes in convenient, easy-to-pour powder sticks that rapidly dissolve in water and make a great tasting drink that has 75% less sugar than your typical sports drink. It uses all natural flavors, and it is gluten-free, dairy-free, caffeine-free, non-GMO, and it is vegan. And you can find Hydrolite Plus by visiting hydrolite.com/Dr. Drew. Again, that's HYDRALYTE.com/DRDRW. And be sure to use our code Dr. Drew 25 at checkout for a special discount. Thank you to Flipping Birdies, as always, for the support that He offers us, we're talking Dr. Bruce Patterson, he and Dr. Yogendra are doing some breakthrough research on the long haulers. And there's my feedback a little bit. We got lots of calls. How do you feel, Dr. Patterson, about the, I don't know how else to frame this except then the public health sort of response and how the public health community has dealt with this outbreak. Do you have any thoughts about that, or would you prefer not to talk about it?
Well, again, I've kept my head down and focused on the science, but at the end of the day, this is unprecedented. And, you know, I think everybody's trying to do the best they can. I think the whole nature of the beast, the nature of lockdowns and stay-at-home orders, these are things that we're just not used to as a society. I think it was, you know, my colleagues in Wuhan, it was easier for them. They were ordered to stay in their house and they locked the door. There was no grocery stores. There was no getting gas. There was no, you know, exceptions to the rule. And they saw their virus drop, you know, to virtually zero. But that's just not what we're built on in terms of the foundations in the U.S. and freedoms and such. And so it's been difficult. And just like HIV, this virus never seems to, you know, stop surprising us at times. And so we've had 2 steps forward, 1 step back, and it's a moving target, and it's difficult, and I'll leave it at that. But
I just don't understand why we abandon all our good public health practices that we developed during HIV and AIDS and learned so much about what works in terms of changing people's behavior. We never said, you're going to kill people with that virus. We said, hey, if you wear a condom every time. If you don't, you're having sex with everybody they've ever had sex with. We did a lot of great encouraging, positive. We didn't call people murderers if they transgressed or if they had the illness and were spreading it asymptomatic or whatever. I mean, how we've abandoned all that in the name of this "you're a murderer" kind of mentality is just beyond me. I can't believe it.
Yeah.
That's why we're not getting it done, it seems to me.
I think the other thing we have to be prepared for is disinhibition, which is what we saw with HIV in the mid-90s when the protease inhibitors came out and really extended people's lifetimes to, you know, by 20 or 30 years and allowed them to live a normal lifespan. And we saw a increase in the, you know, the risk-taking behavior and you know, that was part of having a successful therapy. And my fear is that with the vaccines, which we don't know, you know, long term what the response will be to the vaccines, that the minute a needle goes into the arms of people around the world, the masks come off, the parties start, the bars open, and we have a situation that could be horrendous. So that's my concern because we saw it in HIV. Again, there's lessons learned from history.
Let's take some more calls here. I've got lots of stuff coming in. This is Richard. Hey, Richard.
Hey, how you doing?
Good. What's up?
My question is for Dr. Patterson. First, I want to say thank you to Dr. Patterson and everyone at IncelDX. You're doing great work and you're helping a lot of people. My question is, Dr. Patterson, if you're diagnosed with COVID-19, a moderate case, perhaps headed towards severe, what would be your one therapeutic of choice, whether it be approved or investigational?
Well, I mean, I love that question. I get it probably 3 or 4 times a day because it's such a good question. And I think, you know, the difficulty is approved plus investigational. I mean, I can only take what I have access to. And right now, you know, Maravirac and, you know, and convalescent plasma is probably, a choice that covers both the viral replication and also the immune response. So,
and you would take
right
that
now,
in mild, moderate cases, or in any case?
I think I would never take anything for mild cases, and that's where diagnostics come in. I mean, again, our bioinformatics model modeled the immunology of mild, moderate, and severe. And one of the interesting things that came out of our bioinformatics is we could easily model, and this is coming out of in the paper, what the severe immune profile looks like and who's going to become severe. But what was equally interesting is when we looked at mild to moderate patients, there was 2, if not 3, subsets immunologically of patients. So I'm not surprised that companies have run into difficulties doing mild to moderate trials when it is in itself a heterogeneous population. And why would we expect people to respond within that group the same way? So yes, there's a big difference between mild and moderate. Like everybody else, I would certainly wait until I started to see significant elevations of RANTES, IL-6, TNF-alpha, et cetera, before I implemented any therapy.
Caleb, you have the graph queued up, is that correct? Yes. This graph you've provided us, this is your scattergram on the long haulers. Yeah. There it is. Want to tell us what's in that?
Yeah, I think this is really fascinating because it's, again, in collaboration with some great investigator colleagues, friends of mine from Costa Rica, Jose Guevara, Rodrigo Mora. And what we were able to do is model both the severity of COVID, of active COVID, which you see on the y-axis, and the long hauler score, which you see on the x-axis. So yellow dots are long haulers, and over on the far left, the green dots are severe, light blue dots are mild to moderate, and there's dark blue dots down in the lower left-hand corner that are normals. But you can see immunologically how distinct the long hauler group is from active COVID. And we also can use this to say, where are you on the severity index in terms of COVID to help ultimately decide who needs therapy and who doesn't need therapy of one kind or another. So again, this is coming out very soon, but I wanted to put it up here to see, to visually see just how distinct long haulers are in those yellow dots. And I'll say there's several yellow dots that are right on the cutoff. Those are actually long haulers who have been treated. And
wait, say that again. Say that again. I missed that.
There are, I think, 3 yellow dots on the vertical dotted line that represent long haulers that have been treated, have felt better, and their long hauler index has gone back to below, back into the normal range. So
that's interesting.
We're very excited about this graph and how it's able to parse the immune systems of all these different constituents.
And are you looking at that scatter? Are we? It seems to me that it's fairly equally distributed amongst severe and moderate cases. In other words, the severity of the acute illness doesn't predict your long hauler status.
No, it really doesn't. And that's exactly what we find is that we've had patients with mild to moderate symptoms who become long haulers, and we have patients who are severe to critical who become long haulers. So there's no relationship to the actual clinical active COVID period and whether or not you become a long hauler.
I want to go back to the calls here. This is Callie. Callie, go ahead.
So one, I just want to say thank you to Dr. Patterson and to Dr. Yo because I sent them my blood and I'm excited to start working with someone that's focusing on long haul. I guess my question is like kind of a three-part. So I'm in a few like long haul groups, and there seems to be people that have like long haul constant persistent symptoms where you have absolutely no good days, and then there seems to be like long haulers that have no symptoms for months and then it comes back. So do you think that there's possible like a reason for that, or if you look at it that way? And then in terms of long hauling itself, do you think treatment is going to be necessary, or do you think over time the immune system and like the body would resolve itself?
Good questions.
Yeah. Those are great questions, actually. And the fact of the matter is it's so heterogeneous in terms of who gets it, when they get it, how long they've had it. It's really hard to pinpoint, what could happen. I mean, if somebody was absolutely perfectly fine and then, a month or two later got, long hauler type symptoms, you could start thinking about other chronic infections, like I said, CMV, Epstein-Barr, something else that you got during active COVID that was coming into play. We have a paper under review of a patient who had COVID out to 72 days. So again, having COVID for a long period of time is also a possibility in some of these individuals who there was no, they got better, they weren't in harm's way, but they never really felt great, and then all of a sudden started to get worse. So like I said, we've heard hundreds of these stories, and all of them are different. And I think there's going to be different treatment protocols for everybody, depending on what the biology shows. And the last point is, over time, you would think that you develop what's called immune tolerance, meaning you've been exposed to an antigen long enough that your body stops recognizing it as being foreign, at least in simple terms. The other thing we found in long haulers, the ones that are having symptoms, obviously, is a low level of T regulatory cells. That's important because, like I said before, T regulatory cells are the cells that should shut off the immune activation, yet are low in long haulers. So that may also be part of the pathogenesis of long haulers in general, and be part of how we manipulate the immune system to get back to normal.
Very interesting. Something I've been meaning to ask for quite some time, and it just came to me just a minute ago, which is there was some really interesting data on the MMR vaccine and some sort of cross-reactivity with COVID. Did you see that? And it also went so far as to talk about very elderly, obviously their immunoreactivity against MMR may have decayed, and obese people as well don't respond to that vaccine very well. Mm-hmm. So any thoughts about that?
I mean, listen, there's a lot of examples of cross-reactivity in vaccines. I think when you talk about the HPV vaccine, which there's 15, 16 types that cause cancer, and we have a 9-valent vaccine, everyone says, well, what about the other 6? And I think the rebuttal is, well, we hope there's cross-reactivity of the 9-valent with the other 6 to some extent. So it's not surprising where, and there could be some commonality in different portions of the virus and viral proteins that could cause, partial immunity or partial protection from one vaccine or another. So that's not surprising. But, again, and then the other thing with COVID is obviously the sequence variation and how that's going to change over time, and how is that going to affect response to vaccines and potentially neutralizing antibody therapeutics. So moving target, and there's a lot to learn.
It keeps going back to that. We know some things, we don't know a lot. But
exactly. But I think we're moving in the right direction. I wake up every day optimistic, and I feel for all of these people who both are infected, and I really feel obviously for the long haulers. The stories I've heard, at times desperation. These are active runners, athletes who can barely get out of bed, and that keeps us coming to work every day.
Good. Well, we thank you for that. I know that, I sort of was working a lot during the time of chronic Epstein-Barr, so-called, and psychiatry picked up that ball and turned every depression into chronic Epstein-Barr. It was a very weird time. But unfortunately, because of that, we, I think, took our eye off the ball of chronic viral illness, which we've known for quite some time, as you pointed out, exist, and this has brought it back into the forefront.
Well, I think the converse is true. In fact, I know somebody very, very well who had CMV, and conversely, not only had chronic fatigue, but it causes sleep disorders, and they were basically horribly depressed. And so the converse is true.
Right. There's no doubt. There's no doubt that it actually does do that. It's just that it got kind of overdone, and then people ran away from it, and it's time we really sorted that out. So
you bet. And I think it's time we recognize that is out there. I think one message to the long haulers is, listen, there's other chronic infections that are debilitating to people, and they're going through the same thing. So you don't have to feel alone. You don't have to feel it like it's something that we completely don't understand. Like I said, we're getting our arms around it, and we have experience dealing with post-chronic infectious syndromes.
Yeah, and it certainly is not a newcomer to the history of medicine. A lot of young people died of something called consumption back in the day, which was most of which was probably tuberculosis, but a lot of it may have been something else. So the idea of a slow, miserable, demise for infecting agents is not something new to the human experience.
No,
and this is not that. The important thing, I'm saying that to frame that this is not that. This is a light version of it. This is not going to do that to you. It's going to make you make you miserable, but it's not going to be that old syndrome where people died of it.
That's right.
Well, Dr. Patterson, as always, it is a privilege to talk to you. I think you can see how the listeners and callers are lit up by your work, and they're very interested in it. And isn't it interesting how sophisticated people are about it too, which I find interesting. People are. I
mean, I'm very pleased with their level of knowledge. They're taking responsibility for their own care. I don't know if it's through loss of confidence in whoever's taking care of them, but or if it's just that they're involved in their care, and I think that tends to be something that's a trend, and it's very helpful.
Yeah,
I love the ideas.
Yeah, and I would argue that I know my peers pretty well. Most of them would encourage that when we've hit the limits of what we have to offer, which is standard of care for general medicine. Delighted to have you, send your blood to a Dr. Patterson. Delighted that the patient's getting educated about it, because I'll learn something as well.
Yeah, we will. We'll get there.
Again, the website is info@IncelDX, right? info@IncelDX.com. If people want more information. Is there a website other than that email?
Yeah, www.inceldx.com. You can see everything we're doing, both in infectious diseases and cancer.
Great. Well, listen, as always, thank you so much, and keep it up. And if there's more we can do to support, or there's some story you want to get out, please let us know.
Will do. Thank you, Dr. Drew.
All right, everybody, Dr. Bruce Patterson. And shall we wrap it up, Mrs. Pinsky? Is that time? She needs a mic there. She's typing away to
I'm back.
She's typing away to the restreamers.
I asked everybody if they missed me. And I took some pictures of you.
Casey Gates said horribly.
I just, took photos of this place, and I realized we really need to clean this place up, Caleb. I need your help. But I took photos because you've got 2 cameras on you with 2 shows on at the same time now. So I feel like a proper television producer.
Indeed, proper. Listen,
I missed my restream, but I can't do it on my laptop because we're all queued in.
I'm sorry, I'm not going to get to everybody. Alice, your osteoporosis shot should not affect the COVID so meaningfully. Nathan, I'm sorry I didn't get to the somatic symptom disorder. I think you mean somatizing disorder. That's always a risk in there, but this appears to be something more just based on the inflammatory mediators. And someone dropped off who had a question about acetaminophen overdose, and I am telling you, if you took 8 or more tablets, which is what, 4 grams, right? Yes, 8 or more tablets at a time can shut your liver down 3 days later. Go to an emergency room immediately. Immediately. Do not pass go. Tylenol is one of the most toxic medications you can take in a large dose. Your liver doesn't have the metabolism, doesn't have the ability to metabolize it away, so it turns it into a toxic compound that will completely shut your liver down in a couple of days. And there's no turning back. It's liver transplant time after that.
So I have a question.
Yeah.
If we're giving the first round of inoculations to the elderly in nursing homes and their caregivers, and we give all the old people who could die from it this vaccine, can we go back to our regular lives?
Clearly not. Clearly not. Not till we get everybody vaccinated.
Because I mean, if 40% of people dying are, and I don't mean
somebody on the restream asked a question. Their teacher, a kid's child had died in her 50s or something, and when people hear about a death, even though it's less than 1 out of 100, they freak out. So people are not going to let go.
Or people that are obese or have metabolic disorder, they should get it first. And
yes.
But I just feel like if we're giving it out to people that could potentially die first, then doesn't that give us let our younger generation able to maybe go out and live their lives a little bit, not worry so much about bringing it home to the elderly?
Right. That's the question. And what is that point? And by the way, they have to get both vaccines plus 2 weeks. So it's 6 weeks after the first vaccine that the
but it's going to be April
in.
before you and I get it. So
we'll see. I'm pushing for it as hard as I can. But
I don't know. I'm just using my
I understand what you're saying. I understand what you're saying. Is that particularly a young person whose risk of serious illness is very low? It's the flu for a young adult. Should they go about their life?
And if anybody over 70 has it, because they're getting it first, then they're not gonna die from it.
Correct.
So,
correct.
I mean, we might have hospitalizations, but there's a good chance you're gonna live, like 99% chance, right?
If you're what?
Not at risk.
Correct. 99.9% if you're a certain age group.
I mean, just like the flu, or it would be more like the flu, because the flu shot would be given out to people that need it more.
Right.
Which is usually the elderly.
That is right.
And then our family.
And everyone's encouraged to take that flu shot, especially this year. So listen, we're dragging on here. I've got to go.
It's just it's uplifting to know that this could happen, And
yes.
It's like everybody's afraid to think it will.
Well, Dr. Patterson said some stuff in there that got me.
I kind of missed it. I was a little busy.
He got me thinking a little bit about immunity and about how long immunity lasts and what do we do if it doesn't last and we have to prove all that. Look at Susan's picture.
Oh, look, that's me. That's me, not today. I didn't wake up like that. And I'm pretty much looking like I woke up.
But not today. So I am not feeling that cavalier with your logic right now.
Okay.
But you may be right.
But I mean, I was trying to figure out why they picked that first, because you figure everybody in the nursing home is going to die anyways. So why would you give them the shot as opposed to somebody who could go out in the world and contribute to taking care of people or just getting their businesses back? But then I thought, well, if we're not killing off grandma because we went out and had fun, then maybe that's the good route. I don't know. I'm trying to figure out why they picked that group first.
Well, because those are the ones by orders of magnitude more likely to die. And so you're taking people that are likely to have fatal illness from this thing,
right? And they're going to die of something else instead,
right? But you're making the argument that why aren't we looking at years of life lost? Why aren't we thinking more that way?
Right.
And we're not.
And my mom used to always say, "You'll die of something else." So I'm just like, well, why did they pick that category? And it makes sense if they can say, okay, now we can breathe lightly now and maybe go back out into society and not worry.
But then you've got to get the elderly generally, not just the nursing home patients. And
us.
Yeah.
We're old too.
Yeah.
I guess we're at risk. I don't believe it, but I don't want to get it, but I just don't believe it.
And I'm worried about these lockdowns. I'm very, very worried about them. The mental health piece of this has just been insanity. Let's see if there's anything else I can address here. Guys, okay, that's going to be it. We're going to wrap this.
Just give it to all the people that are getting it, which is the Hispanic and Black population first.
It's interesting. The African Americans in Los Angeles are doing better than almost any other group. So
they're not getting it.
Not.
I thought it's
Hispanic.
It's Orange County.
Hispanic are getting it.
The Blacks aren't.
But African Americans are doing I keep saying we need to look at that and figure out why Los Angeles is doing so well. But no one will take me up on that.
I told you when this whole thing started that most of the Hispanics that I knew were still working. The Brazilians, the Mexicans, all the Hispanic people that I work with in
right. So that maybe that's it. Maybe it's unwillingness to sort of distance.
No, they don't. No, they don't stop working. That's just what they do. That's why I love them.
Okay, you guys.
They work 7
We're
days
going to wrap this thing up. I don't know where Susan's going with this, but we will leave it at that. Are we going to be in here tomorrow, Susan?
Yeah, we'll be here with Mia Burke.
Okay, Mia Burke.
I need a headshot of her, Caleb. So, Mia Burke, explain who Mia Burke is.
Mia is the daughter of a friend of mine who has a new sort of newsletter that I found intriguing. And she, I think, is 16 or 17 years of age, and I really wanted to hear what they're thinking, because they are being affected by this lockdown and all that we're going through right now, almost more than anybody. And I don't hear that much from that age group, and she's very thoughtful. She's 16 or 17, I think 16 now.
Oh, I didn't know that.
And let's hear what she's hearing from our peers, and we'll hear what she's thinking, and I thought that'd be very interesting.
Yeah,
so
it'll be fun.
Do
a dose of Dr. Drew and Mia Burke.
A few minutes of that, and we'll see you then tomorrow around the same time, 3 o'clock. See you then.